Bismillah ar-Rahman ar-Rahim. Welcome back, everyone. Today we are going to discuss the second part of the radiology series, and today is about how to differentiate between airspace disease and interstitial lung disease on the chest X-ray. So when we talk about the parenchymal lung diseases in ICU, so we know that the lung diseases are either parenchymal lung disease or airway disease. Now we are talking about the parenchymal lung disease. We can divide them into airspace disease and interstitial disease. So the airspace disease, APO, which is acute pulmonary edema, aspiration, pneumonia, and pulmonary hemorrhage. So you can have a mnemonic of AAPP as an airspace disease, okay? Interstitial lung disease can be either reticular or nodular. So reticular are pulmonary interstitial edema, which is a precursor of acute pulmonary edema, or atypical pneumonia, either viral pneumonia or mycoplasma, legionella, or chlamydia, or scleroderma. Nodular can be bronchogenic carcinoma, metastasis, miliary TB, or sarcoidosis. So all of these diseases are under the headline of parenchymal lung disease. You can add pulmonary infarct as well, although uncommon, but can be added under the airspace disease. And pulmonary hemorrhage is not necessarily hemorrhage bleeding due to Wagner's granulomatosis or Churg-Strauss or good posture, but this pulmonary hemorrhage can be due to trauma. So we can add pulmonary contusions as well in this category. So before we start with imaging, I want to differentiate about the pathophysiology of both of them. So starting with the airspace disease, the opacity will be fluffy, cloud-like, and hazy on the chest X-ray with indistinct margin. And this is the usual consolidation that we see with pneumonia or acute pulmonary edema. So this is the usual consolidation with air bronchogram that we are used to. And these airspace diseases or consolidation will be confluent, so they coalesce with each others and merge with each others, as you can see here. And this is the difference between the normal lung or normal alveolus here and the injured alveolus. And I think most of us have seen this picture before in ARDS pathophysiology. So this is normal lung aeration, and there's some macrophages and type 2 cells, while here, if you can see this, so this is the injured alveolus during the acute phase of airspace disease. So there is a lot of fluid inside, and there's a lot of inflammatory cells which release a lot of inflammatory mediators, as you can see, and this inflammatory mediators will cause swelling and inflammation here, and this will impair oxygen and gas exchange. And by the end of the inflammation, acute inflammatory phase, the alveolus will fill with fluid and edema. Either this edema is due to acute pulmonary edema, or this edema is due to acute severe inflammation due to pneumonia or any type of ARDS, and that will impair the gas exchange between the alveolus and the blood vessel here. While the interstitial lung disease occurs in the interstitial space, and this interstitial space is the space that is surrounding the alveoli, here around the alveoli, okay, and separates the alveolus itself from the blood vessel. And inflammation in this space will impair gas exchange again and will cause scarring at the end. Other one will cause scarring, but the alveolar disease, but the scarring will be inside the alveolus, while this one will be in the space between the alveolus itself and the blood vessel here. So this one is the interstitial space. And this space contains connective tissue, blood vessels, and lymphatics. So how does it appear in the chest X-ray? It appears as particles of disease with sharper margins. We said that the margins of the airspace disease are indistinct and confluent, but while interstitial disease will be sharp margins, and these margins will be inhomogeneous, and they are separated by normally aerated lungs. And we'll see the difference between them in the chest X-ray itself. Alright, so first example here, 55 years old male, presented to ED with fever and type 1 respiratory failure. What do you think about the chest X-ray? So in these lectures, we are talking only about recognizing pathology, but we will talk about how to interpret the chest X-ray or any other radiology image in the FCICM exam, but that will be in next lectures. So now only talk about pathology. What we can see here is a right lower lobe area of increased opacity, so area of consolidation with air bronchogram, and the right lower lobe. It's confluent, fluffy with indistinct margin, and you still can see the right hemidiaphragm here, and there is no signs of effusion. And you still can see the right heart border here. So this is a right lower lobe pneumonia. And very important to take into account the presentation that the patient came to ED with. So he came in with shortness of breath and fever. And if you see the chest X-ray here, so that is typical of bronchopneumonia. So I just wanted to touch base about the air bronchogram that I mentioned in the Airspace disease here. So bronchi are normally not visible because their wall are thin and they contain air inside, so they are not visible. And they are always surrounded by air in normal lung. But when something like fluid or soft tissue edema will replace the air that is normally surrounding the bronchi, then the air inside the bronchus becomes visible as a series of black branching tubular structures, and this is what is called the air bronchogram. So the air bronchogram is actually the air which are inside the bronchi, but now it is visible because it is surrounded by fluid. And this is diagnostic of airspace disease, whether that airspace disease is APO, pneumonia, aspiration, or pulmonary hemorrhage. Right now, talking about this chest X-ray. Clinical context, 35 years old male, presented to ED with heroin overdose. So again, opacities all through the both lungs, fluffy, hazy, cloud-like with indistinct margins. That points out to airspace disease. In the context of having heroin overdose in such a young man, this is most likely an acute pulmonary edema. So you can see here, this is an atypical distribution of acute pulmonary edema, and it's like more apical rather than perihilar, so it's here. Usually the acute pulmonary edema is like bat wing appearance and arise from here. But this is in the clinical scenario here, goes more with an acute pulmonary edema. And its appearance of more of an acute pulmonary edema rather than aspiration. So this is the appearance of air bronchogram in the chest CT. So you can see this branching structures here and here, which represent air that is now visible inside the bronchi because of the surrounding air spaces that are filled with inflammatory fluid and edema and exudate, and that's because this patient has pneumonia. And normally in the normal CT or the chest X-ray, these branching structures are not visible because the bronchi are very thin and are surrounded by air, so it's not visible. But here it's visible because of pathology. So this case, 38 years old female, presented to ED with shortness of breath and fever. What pathology can you see in the chest X-ray? So we can see here consolidation with air bronchogram, confluent, fluffy, cotton-like, hazy appearance of airspace disease with indistinct margins. You can really see that there is no distinct borders or margins of this consolidation. And this black solid arrow points to what we call a silhouette sign. So silhouette sign that you cannot see the right heart border here clearly, which is this one. You cannot see the right heart border, but you still can see the right hemidiaphragm. And this is called silhouette sign. And it indicates the presence of pneumonia. So again, another X-ray, 58 male patient presented to ED with non-STEMI. So this is typical appearance of acute pulmonary edema. So bat wing appearance, perihilar. Again, fluffy confluent consolidation with indistinct margins. This is another X-ray with streptococcal pneumonia. So consolidation with air bronchogram here. Confluent, fluffy with indistinct margins, but you can see that the minor fissure here causes sharp demarcation of the border of the consolidation. So another X-ray of 68-year-old man presented to ED with low GCS. What do you think about this chest X-ray? So the history plus the distribution of the lesion here raises suspicion about aspiration. So basal appearance of confluent, fluffy consolidation represent an airspace disease. There is some minor similar appearance on the left as well, so bibasal appearance with the history of low GCS. So that represent aspiration. So this is the appearance of pulmonary interstitial edema, secondary congestive heart failure. So this black circuit represent increased bronchoalveolar vascular markings, and the white circle represent curly B lines, which is thickened interalveolar septi and full of fluid. And this represents congestive heart failure. So the congestive heart failure can represent as an APO, acute pulmonary edema, which is confluent, fluffy, hazy, cotton-like appearance of consolidation, and usually is perihilar, or the interstitial edema, which is increased bronchovascular markings like this picture. So this is the appearance of interstitial pneumonia or atypical pneumonia, viral, or Legionella mycoplasma or chlamydia. Or if this pattern is bilateral, think about PJP in an immunocompromised patient. And this is reticular interstitial markings represent fibrosis. And this is like a close-up at the lung basis. This is another image represent metastasis, so multiple discrete nodules widespread all over the CT chest with variable sizes. And metastasis is a diagnosis of exclusion. You have to exclude other causes first and look for a primary. This is a mass in the right upper lobe of the lung. So again, consolidation with indistinct margins, which is suspicious of malignancy, and the CT confirmed adenocarcinoma of the lung. So this X-ray is in a 45-year-old man, fever, shortness of breath, and lymphadenopathy. What do you think? So this is a diagnosis of sarcoidosis. Represents perihilar bilateral paratracheal lymphadenopathy, which is a classical distribution of lymphadenopathy in sarcoidosis. Plus that the patient has diffuse bilateral interstitial lung disease, reticulonodular, and this patient later with treatment can have lymphadenopathy regression, and some patients have like persistent interstitial lung disease, but with treatment some of the patients actually may recover. So this is the chest X-ray of an 8-year-old boy who presented to ED with fever and loss of weight. What do you think? So this represents primary tuberculosis. You have unilateral perihilar lymphadenopathy. So perihilar lymphadenopathy may be the only manifestation of primary TB, especially in children. And you have here what looks like a consolidation with air bronchogram. That's in the left upper lobe. And you have another one here, which is another consolidation with air bronchogram of infection. So infection in the apex of the lung, pneumonia, apical pneumonia is a common finding in TB, which will be bacterial superadded infection on the tuberculosis. And we have some lower consolidation here, which might represent, again, bacterial superadded infection, but the upper lobar infection in TB is more common than the lower lobes. Another TB patient, what do you think? So this is large left pleural effusion, and in the context of TB, that effusion will represent exudate that can cause after primary or secondary TB, but it's more common with the primary TB. And because it's exudate, it has tendency to cause loculations and septations, and it will be a complex effusion and might need thoracotomy. So if I give you a history of TB, what do you think about this case? So there is cavitating pneumonia in both upper lobes with multiple cavities, with another consolidation with air bronchogram around the lingula. So another patient with TB, what do you think? This is tuberculous bronchiectasis, and upper lobar tuberculous bronchiectasis is the most common site. This has small multiple cystic lesions, as you can see here in this circle, represent honeycombing, which can be seen after TB. So another patient with history of TB, what do you think? So this is a miliary TB. We can see here multiple innumerable small round nodules widespread all over the lungs, and they are about 1 millimeter or more in size, and when they reach to this size they become visible, and miliary TB represent blood spread of TB. So this concludes our lecture today about the parenchymal diseases of the lungs. Next lecture will be about differentiating and how to differentiate between effusion and atelectasis in the chest X-ray and CT. Thank you.